We'll get going. I'm conscious of timekeeping here, so I'd like to welcome you all to Research Week 2025. Some people here we haven't seen since Research Week 2024, which I don't know what that says about us, but thank you all for taking your time to come to today's event. Just a little bit of housekeeping, if you wouldn't mind to put your phones on silent, just for the speakers. There is photography and videography here today. If any of you would not like your photograph taken, contact one of the team behind you there at the back of the room, Richard and Lana. So without further ado, thank you so much, first of all, Laura, for planning this event and for being part of our Research Week programme. We're delighted to have you guys. So I'll hand it over to Laura. Laura will talk to you about CIRcUL. Thank you.
You're all very welcome here today, and thank you very much to all those organising from Research Week and also to the HRI for supporting this event. So, today's workshop, I'm going to start by way of an introduction. So, we have quite a diverse audience of attendees here today. So, what I'm going to do is sort of general talking about implementation research, take you through a few of the frameworks that we often use, I suppose the more prominent frameworks that are out there, and try and bring everyone together on the language of implementation research. So a big challenge in implementation research is that within our different disciplines, we use different terminology to talk about the same thing. So I'm going to do that general piece, then I'm going to introduce a workshop problem for today. So something that I want you to think about as you're listening to the other speakers, and I'll put up some questions about it for you to think about. Then we'll have three speakers. I'll introduce them all in turn, but we have Geoff Curran, Allison Metz, and Laurence Taggart, apologies. And they're going to talk about fidelity, implementation support practitioners, and readiness. And they have 10 minutes each, and there'll be time for one or two questions from the audience for each of those three speakers. And then we'll come back to the workshop problem. I'll talk you through how I would have solved it from an implementation science perspective. And if we have time, I have a slide on ethics of implementation research, which is a very niche area, and there's some very, very new writings on the topic. So if we have time for that, we'll finish with that. So let's get started. So when we have an intervention or a change we want, we think of what is the intervention, who are the stakeholders, and where are we going to do it? They're the first big things we think about. And we can throw them all into a funnel and hope we're going to get the outcome of interest. And very often that's exactly what we do. That is definitely what policymakers do. You'd see any policy document and it tells you all the lovely, lovely things that they want to achieve. And then there's a short paragraph that says, now we're going to implement it, it's going to be great. And of course it's not, because there isn't an implementation plan to underpin it. So what can we do to move us away from this haphazard approach to getting to the outcome of interest or the desired outcome? Well, that's where implementation science or implementation research comes in. And it's about how do we order the input? How do we do the thing? Not what do we want to do? How do we do it? How do we go about it? And there are enormous amounts of evidence-based theories, methods, and frameworks to rely on. Within implementation science, there's probably 170, if not more, of these. I'm definitely not going to take you through all of them today, but I have chosen four that to give, like I said, to bring people along this journey before we go into the in-depth external speakers. So some of the things we like to do within implementation research is first is identifying the stakeholders. And actually, this is more than just having a quick think about who should be involved. This is a detailed, process-driven, evidence-based approach to going through the stakeholders, looking at the stakeholders right down on the ground, pulling it all the way up to policy, who should be involved. We work very much in the area of understanding enablers and barriers. So barriers are things that are going to get in your way, and you need a plan to overcome them, and enablers are things that you can use, you can leverage to affect the change you want. We work to support fidelity. So fidelity I'd say everyone has an experience of having a great intervention, and it was there on for another little while, and then you went back and looked at it a year or two later, and it had morphed into something else. So ways to support sustainability are part of implementation research. We work in the space of evaluating the impact of an intervention. So not just evaluating whether it met the outcome of interest or not, but the more general impact of it, the implementation impact, the implementation outcomes along the process. We work to promote sustainability. So not the sustainability we're always talking about in UL, but the other sustainability of, will this intervention, will this thing still be in place after either the researcher or the key stakeholder steps away from it? Is it sustainable into the future? And we work in the space of managing knowledge translation. That's a key piece of implementation research. How do we communicate with all the different levels that need to be communicated with? Because implementation research works not just within one sphere, but it actually transcends all the different levels of society. We're not just talking about doing an intervention with a group of people, a group of patients, a group of workers. We're talking about those group of workers and the higher level organisational people and the system. So you have very, very different knowledge needs and communication needs across the group. You're also talking about the general public, because most of the work that we do has a societal impact. Big challenges in implementation research, and the ones that there are good methods to underpin ways to circumvent. We're working in an area of varied contexts. So you need, something might work in one place, but may not work in another place. And you need strategies to evaluate the context and adapt the intervention so that it does work elsewhere. We're working in complex systems. So the space we're talking about is not just, oh, can we bring in a change in this room here? It is the big complex system of this room is within the university, this university is within the state, and all those things that interact. And how do you grapple with that? We have the sustainability challenges, which I just outlined. We have measurement and evaluation challenges, and we have stakeholder engagement. Like I said, you have many different types of stakeholders with different types of needs. So the first framework that I would like to, well, this is a model actually, that I would like to introduce to you is the knowledge to action model. So this one is about the knowledge to do gap. If we know something, we know this is best practice, we know this is evidence-based, we know this is the thing that we want to be doing, and everyone agrees this is what we want to be doing, but we're not doing it. There is a gap. That's the no-do gap. And it's implementation research that comes in there to bridge that gap. Sometimes we know there is a gap, but something that's really important is asking ourselves why there is a gap. Because the why there is a gap, those are the things that feed into building your implementation plan. So this one talks about, you'll see it's a continuous cycle. It talks about monitoring the knowledge use, evaluating outcomes, working to sustain the knowledge use, identifying problems, adapting knowledge to local context, that same sort of thing, and I'm talking about the different stakeholders. Now you've got different contexts as well, mapping on top of it. We're assessing barriers to knowledge use, and we're selecting and tailoring our implementation interventions based on that. But we keep doing it, keep going around in the cycle constantly. This framework now is probably the most famous one. This is the CIRcUL, Consolidated Framework for Implementation Research. And it is a process to help support identifying enablers and barriers. So it breaks down the implementation into 5 domains. You have the inner setting, which is the structural characteristics, the culture, the tension for change. Tension for change is a really interesting concept. So you might want change. So I'm standing here, I want change. And I want all of you to change. But none of you feel like changing. That means there's no tension for change. You need to create that need or want within the people that you're trying to change. So that's all part of the inner setting. Then you look to the outer setting. And this is hugely important. This feeds back into the complex systems within which we work. So this is looking at systemic conditions, at policy, at law, at partnership, about how something is funded. So they're the two big ones. Then we have to look at the actual people, the individuals. Do we have, who are the stakeholders? Do we have opinion leaders in there? Opinion leaders are vital. Do we have implementation facilitators? Do we have champions? Champions are people that really, really want this and will go out and tell everybody that they want it and that they should do it and why it's so great. Crucial individuals within any implementation or implementation of anything. Then we have the implementation process, and you have all the different subdomains and constructs within that. And the what. The what or the thing. There are two phrases we use very commonly. The what or the thing. And that is the innovation. What is the thing you are actually trying to implement? Can you define the thing? Because if you can't define the thing, and very often we can't define it, it's really difficult to define. If you can't define the thing, you can't get to your outcome. Okay, this is a very, very old theory. This is Rogers' diffusion of innovation. And this is talking about the different stakeholders and the people that you're trying to impact. So first you have, people adopt change, adopt an intervention along their own timelines. You have first the innovators. So these people are the people who are really excited by something. They have seen it, they've heard about it, and they're very excited about it, so they adopt it really early. Then we have the early adopters. These are the next group. And these are the group that they've seen the innovators. And there's a little bit of this kind of social interaction where they've seen the innovators doing something good and they'd like to do it too. So they do it, take it on as well. Then we move into the early majority and the late majority. They're kind of similar. They do it out of social pressure. Everybody else is now doing it, and now I have to do it too. They're those people. And then we have the laggards. The laggards are actually really like the innovators. They have a freedom, a mentality of freedom. So it's kind of like, I don't need to take this on. It's that type of attitude. And they're actually really, really important people to have in society. They're the very free thinkers and alternative way of doing things. But if you really want to elicit change, they're the hardest group to change. That moves us to normalization process theory. So this is the last one that I want to introduce. This is known as MPT, and you can use this either to build your implementation plan or to evaluate a project. So it's very useful. And it focuses on 4 different domains: coherence, cognitive participation, collective action, and reflexive monitoring. And coherence is about, does everyone want to do this? Is there an appetite for it? Cognitive participation is about building a community of practice. Or can we increase the skills? Are people going to feed off each other? Can we get people behind this? The collective action is the actual implementation, the things that you are doing. And the reflexive monitoring is evaluation, effectiveness evaluation, but it is back into that cyclic way of working where everything is feeding in, the implementation process changes a little and adapts because of the input. In a way, implementation research is different from something like a clinical trial. Clinical trial, what you're doing can't change from start to finish. Otherwise, it's a completely flawed trial. But implementation research is supposed to be adaptive, and it's supposed to take constant monitoring, feeding in, and adapt based on what is happening. So that brings me to today's problem. So you are absolutely free to think of a problem from your own work, but I have a problem here, and I will work through it on the far end. So the implementation challenge is the lack of uptake of Ireland's retrofit scheme. So the retrofit scheme is about bringing existing housing stock up to higher energy efficiency. And this is a quote from RTE only a few weeks ago. Unless Ireland learns fast and acts boldly, its retrofit ambitions risk freezing before they fully take off. So just in the face of this, you have Ireland's retrofit scheme. The government made a policy, they put a big budget behind it. All the money from it comes from the carbon tax. And then they set these very aspirational targets. I can't remember exactly what the targets are, but we're nowhere near them, yet nothing is changing, nothing is adapting. And it's because there's an implementation gap, there's a lack of an implementation plan. So the types of questions that I want you to be thinking about while you're listening to the other speakers, and then I will go through some answers to these. And this slide will disappear now for the other speakers, but I'll bring it back up again, and you'll have a few minutes to think about them. So what is the problem? Can you define it in one sentence? So that's what I was talking about earlier. Sometimes it's very difficult to define the problem. Is there sufficient interest in solving the problem? If you don't have sufficient interest in solving it, think back to Rogers' diffusion curve. You're not going to get those people on board. So it would be a failed intervention. What is the no-do gap? So again, the thing that we know works versus what we're doing in practice. What is the gap? And why does the gap exist? And what can we do? So be thinking about this in the context of the lack of uptake of the retrofit scheme, or if you want to do your own problem, that's absolutely fine. Okay, so at this point, I'm going to, Daniel, will you help? Thank you. I'm going to introduce Professor Geoff Curran. So Geoff Curran is the Director for the Centre of Implementation Research at the University of Arkansas. He has been hugely instrumental in the setting up of our centre here. We have modelled it based on his centre in Arkansas. He's a professor of pharmacy practice and psychiatry and a research health scientist. His broad research area has been in health services research with a focus on the diffusion of innovation in a variety of healthcare settings. So Geoff has over 20 years of experience. So I welcome you, Geoff. Geoff's going to speak to Fidelity.
Okay, so let's get rolling. So I'm going to be talking about Fidelity. I think Laura asked me to talk about this as it's a thorny and juicy issue. So we only have about 10 minutes, so I'm only going to cover a few basic concepts and then stop for questions. Let me just make sure that these are rolling. I just like to note my current funders, mostly from the US. I also like to note that for 25 years, part-time, I worked in the healthcare system of the US Department of Veterans Affairs, which is a federal government healthcare program for our military veterans, and they have been a leader in implementation science in our country for a long time, and I was very grateful to have that opportunity to work for them. I also just like to note at the start, for folks who haven't seen me give a talk before, I have a stutter. I also tend to get nervous when I give talks, even on Zoom from far away, but I should calm down shortly. Actually, this has already been covered, so I won't need to really summarize this. However, I do like to say that I've worked mostly in the healthcare sector and in health systems for a long time. So I'll be talking really kind of from the clinical research perspective. I also just like to note, too, that for about the last 10 years, I have been spending a lot of time working on implementation work in pharmacies and with pharmacists as implementers. So Laura, I heard her using the thing language, so I don't need to cover this. About 5 years ago, I put out a paper to try to frame our field in very simple language, and you will hear me too use this sort of term of the thing to reference the intervention, the practice, the innovation that is the focus of our uptake work. I'll skip down to the bottom. In the paper, I kind of boiled down the topic of implementation outcomes to kind of two basic buckets: how much and how well people do the thing as often our key implementation outcomes. And today, the topic is on how well that we are able to get folks to do the thing, or fidelity. So in implementation research, fidelity is usually a dependent variable. I have a study now where it is the dependent variable, where we have powered our whole study on that outcome. Implementation strategies are often our interventions that our field is trying hard to produce, and a common target of those strategies is this topic of fidelity or outcome. We're trying to figure out which strategies work to get good fidelity. We also want to be parsimonious and sort of, do a cost-effective approach at creating fidelity. In our field, we also look at and are able to look at how much fidelity might we actually need to get the outcomes that we're looking for. Sometimes you're lucky and you don't have to deal with fidelity. There are times when some of our things, there's not really a quality of delivery component. For example, in the pharmacy setting, we have a lot of people focusing on increasing uptake of vaccines, and we don't really study the quality of vaccine delivery. Maybe we should, but it's often not covered there. So those kinds of studies really only focus more on outcomes like adoption or reach. But a lot of us have to deal with trying to measure and understand how well we are helping people to do the thing. And measurement of that can be a real challenge. And I have a few slides on that coming up. So definitions, in lay language, it's basically how well people do the thing. From the clinical research area, there's often an assumption that these interventions were the subject of positive randomized trials. So hence there is some sense that there is a quote unquote right way to do the thing. And if you're lucky, the developers of those interventions have already created a good way to measure fidelity, but we're often not that lucky. In the implementation field, we've kind of modified this definition to focus more on the extent to which core intervention elements are implemented as delivered. And this is getting at a point that Laura hit at a number of times in her intro. In implementation science, we often teach and preach that it's going to be important to adapt the thing for context, for who might deliver it, for who might get it. But at the same time, we also want to promote fidelity of delivery to the thing. So we end up having a bit of a key tension here. We know that we are probably going to have to adapt the thing for better implementability, but not too much. And so how far can we go, and how far might be too much? Okay, so our field has been talking a lot about this for several years, and so we're coming to terms with a few of these concepts that we have to deal with in order to try to make this balance between fidelity and adaptation. So folks in our field talk about trying to understand the core elements of interventions versus what might be termed an adaptable periphery. A core element, sort of in the most formal sense, in the ideal maybe, are like empirically demonstrated mechanisms of action of the thing, but we don't always have those. So there are times when we use other approaches to sort of name the core elements. Maybe they're indicated by theory or some expert panel, and or working with end users to sort of get their input. In more recent writing, we're talking a lot about functions and forms of interventions, with this notion that we should try to stay true to the function of an intervention, but maybe be able to adapt the form or forms. For example, we might have this intervention whose function is help navigate patients through complex interventions and or healthcare systems, but the form of that navigation might come in many and varying ways. It could be a care manager on the phone, it could be some handouts, there could be some text nudges. So there are varying ways to do the function, and we could possibly adapt the form to the context. Just as a brief aside, adaptation of interventions is sort of a topic of its own in our field, and here's a few papers. I'm happy to make these slides available if you'd like to read more, but there's a lot of people who are just actually focusing a lot of their time on that issue. Measurement is a key challenge when we're talking about fidelity, and I'm going to boil down a lot of work here to just a couple of simple concepts. When we're trying to measure fidelity, we often focus on two basic buckets: adherence and competence. The former is more focused on like the extent to which people covered or tried to cover all of the elements of some intervention. Lots of the measurement here shortly is sort of counts and amounts. So did they do the 10 sessions that they were supposed to, for example? The more complicated one is competence, which is dealing really with the quality of delivery, the extent of skills that the people showed when they were delivering it, principles applied or not. And to do this side of it, ratings of some kind are often required, often by experts, and I'm going to cover that very briefly. You have to keep in mind that there's a lot of potential moderators and mediators that are at work here, which you might also want to measure things like characteristics of the intervention, the people getting it, the people giving it, the context, and I'm not going to deal with that last part until later. How to measure? We basically measure fidelity in two ways: directly and indirectly. Directly is often the more rigorous, where it involves going out and watching people do the thing, either live or through some audio or video recording. This often comes with experts with rating scales, and then they sort of do these expert ratings. The indirect approach is less costly. It's trying to work with data that is either already there, like from the medical record, documenting number of sessions and number of groups and who showed up and what we did and what we didn't do, maybe asking people to sort of do logs of their intervention delivery, or possibly surveys or interviews of implementers or people who were getting interventions. There's many considerations you have to pay attention to when you're thinking about developing fidelity measures. First, do they already exist? If you got them, use them. There's a growing literature here. There are places where people have compiled these measures, and that's great. The fact is, we often have to make up our own, because our thing is our own thing, and maybe it has never really been studied from a fidelity perspective like this. There are frameworks out there, literature with guidance, A key factor is how many euro do you have to throw at this? If you're doing this for research, you're probably going to have to approach with as much rigor as you can. If you're doing more of a real world approach, you might want to, be more practical and maybe use some of the more indirect approaches. This is my last concept to raise. I hate to bring this up, but we have to also pay attention to the fidelity that the implementation strategies we might use to help fidelity for the thing. So we have to care about fidelity to implementation strategies. We have a lot of these, and some really need a lot of skill in their delivery. The field is paying more attention to this, so stay tuned. There's a number of books and a great new paper out, and there's a couple of places where they have tools, they have measures. Highly recommend that you seek those out. I'm done. Thank you.
Thanks very much, Geoff. Daniel, can you put my camera back on? Thanks. Does anyone from the audience have any questions for Geoff? He's all the way in Arkansas and got up early. We can't leave him off that easily.
But I'll be at UL in about 6 weeks.
Yes,
so
Geoff is coming
I can
over.
come and meet folks then.
Yes, Geoff is coming over in early June and has offered to do a guest lecture for us. Okay, well, if there are no questions from the floor, Geoff, thank you so much. And we'll move on to the next speaker. I'll talk to you soon. So the next speaker is Professor Allison Metz. So Allison is the Director of Implementation Practice at the University of North Carolina. Hi, Allison. She is a professor of practice, and as I said, the Director of Implementation Practice at the School of Social Work and also a faculty fellow at the Frank Porter Graham Child Development Institute. She's also an adjunct professor at the School of Medicine at Trinity College Dublin. So Allison is going to speak to us. Well, actually, I'll let you introduce your topic, Allison. So do you want to share your slides?
Yes, sure. So like Geoff, I'm going to hope I can do this. So we'll see.
Well, we can hear you anyway, so that's step one.
That's wonderful. Okay, that was step one. So tell me, are you seeing these? Okay, that it always feels like a small miracle. So that's wonderful. So thank you so much, Laura, and thank you to you and the center for inviting me. I'm really happy to be here and really happy to share space with Geoff and Laurence as well. So I'm going to be spending some time talking about developing a workforce to support implementation. And I'll try and make some connections, even though these feel like completely disparate topics. I'll try and make some connections to some things, Laura, that you and Geoff have already spoken about. So I like to often start when I give talks, even short talks, about just sharing my point of view around implementation science. So kind of the perspective I have on it. And hopefully this perspective kind of gives you a sense of why I might focus on the topic I'm going to focus on today. So when I think about implementation science, I think about it in three ways, and they are interrelated but yet distinct. So the first is how we use specific theories, frameworks, models, and strategies to support implementation. So Laura talked about that in her introductory remarks. So, potentially how we might use a determinant framework like the Consolidated Framework for Implementation Research to identify our enablers and barriers to implementation. How we might use a specific model, that might be a process model that gives us kind of a set of phases or stages that we want to move through. And so in the field of implementation science, the use of these theories and frameworks and models is really a common driving factor in how we do our work. But the second way I think about implementation science is how we create a practical implementation science. So some of these models and frameworks can often feel a bit overwhelming to individuals who are working in different service sectors, whether that's in public health or behavioral health or education. And so the use of those frameworks could feel sometimes a bit complicated. And so I think it's kind of on the field to be able to translate those frameworks into things that are quite user-friendly. So those could be different resources or tools. You might even think of checklists that we might put in place to really bring the best to bear of implementation science into the work that we do, but doing it in a practical, easy way. And then finally, my talk will focus on this third area, which is the development of specific competencies that really support our ability to promote good implementation practices. And so when I think about this, I think about it because I think we could be using the best framework or the most evidence-based implementation strategies, but it does take a set of skills, a competency to be able to effectively support implementation efforts to kind of shepherd them through kind of an early phase to a phase of sustainability. And I also have kind of specific interest in what I see as a very understudied aspect of implementation, which is really the relational aspects of implementation. So the importance of how we co-create with the communities that we're working with, how we build trust, how we repair trust, how we support psychological safety among various implementation partners doing the work together. There has been a growing interest on this topic of competencies. So in the research field, the research side of implementation, there are competencies for researchers. So how it is we design our studies, for example, the types of measures we might use, how we might engage stakeholders in the work. But I have a specific interest in a set of competencies that are quite applied as we do work in community or in government systems or voluntary service sectors. And this growing interest, I think, is shared by others in the field. There's been a lot of recent publications on describing the competencies needed to be effective in supporting implementation and evidence use. There have been some growing calls to really address what is seen as an emerging gap between implementation research and implementation practice, sometimes called the ironic gap or the paradoxical gap, which is that implementation researchers who are really charged with identifying strategies to support the use of evidence and practice, sometimes their work ironically can feel disconnected from folks actually working in those service systems. And then finally, there is some emerging evidence. This is Annette Boas has done a lot of work in this area, who's at King's College in London, that the use of different multifaceted implementation strategies to support the use of different innovations in health and social care does still have some limited effects on population outcomes, which essentially means that the strategies alone, whether they are evidence-based and effective implementation strategies, and Geoff pointed to the fact that those strategies take some skill to be able to use. And if we're not using those strategies well, and if we don't have a workforce that can really support implementation, those strategies alone often won't lead us to those population outcomes. So myself and some colleagues have coined this term of implementation support practitioners. So these are practitioners who are focused on providing implementation support. I think the framework that comes to mind for me is a Wandersman work around the interactive systems framework, which talks about the support needed in service delivery systems, again, to really ensure that the use of implementation strategies to bring an innovation to life, to be able to sustain it, to do so with quality, really does take some additional support from a set of professionals that can help to contextualize and improve the use of specific strategies in different service settings and to build capacity in those organizations and systems to be able to move through different stages of implementation. So our team over the last 7 or 8 years has done a lot of research on these competencies using different methods. We had several papers come out from an integrative systematic review. We've also collected survey data and also qualitatively have gathered information through guided discussions and focus groups with individuals who identify in their role as supporting implementation kind of on the ground, if you will. So this has yielded a set of 15 competencies across 3 domains. These domains include co-creation and engagement. You'll note that in Laura's introductory remarks, she spoke quite a bit about how we engage stakeholders in the work, how we co-design or co-create with the communities and systems that we're working in. So you'll see some competencies that kind of cluster around this domain, including how we address issues of power in the work that we do. You'll see the domain ongoing improvement, which you might think of, automatically as how we use data for continuous improvement and conduct improvement cycles in the work. And we would be doing so to improve things like fidelity. But you'll see some other competencies in there around how we continually assess needs and assets, understand context, really facilitate the work among different partners and how critical that is for ongoing improvement. And then finally, how we sustain change. And you'll see there that there's a heavy emphasis on relationships and teams and leadership as really critical for sustaining change. So wanting to have a skill set that can help grow relationships among different implementation partners, develop those sustainable teams, and cultivate different leaders and champions that can help build capacity in those systems. Our hypotheses that we kind of put forth in a lot of the different papers that we have is that those individuals that really know a lot about implementation science, so these individuals would not be kind of generic consultants, but would be individuals that have a strong background in implementation science, often are researcher practitioners. Myself, I conduct a lot of basic implementation research, but also do a lot of this work on the ground. So individuals in this role would bring a set of knowledge and attitudes and skills to the work. They would be incredibly familiar with the different frameworks and evidence-based strategies that the research has deemed really important for implementation science. In doing so, they are individuals that can be perceived as credible in their work in supporting implementation. And the individual stakeholders in the different service sectors that you'd be working in would benefit. Their relational capacities would grow as they feel a deep sense of kind of trust in the work. They would have capabilities to support implementation would increase over time. They would see that they have greater opportunity to improve implementation, and they'd feel more motivated to support implementation. So you can see those levers of behavior change really identified by Susan Michi and her colleagues, that we believe that effective implementation support practitioners can grow relationships, increase implementation capability, opportunities, and motivation when those implementation support practitioners have the right skills. We believe that it's really important to measure the extent to which individuals supporting implementation have these skills. We think it is an understudied facet of implementation science to be able to measure how those knowledge, attitudes, and skills used by professionals supporting implementation affect the sustainability of change efforts in the complex service systems that we work in. So with that in mind, we developed an implementation support competencies assessment and conducted a psychometric evaluation of that assessment. And a bit of a spoiler alert as we move forward, I am presenting this. It's been published in Implementation Science, and we've been able to demonstrate that the assessment that we developed demonstrates internal consistency, reliability, factorial validity, and construct validity. And I'm going to walk through that very briefly, given the time that we have, so just a couple minutes. But I noted that we had those 15 competencies, and you can see those on my left on the screen, and ranging from how we broker relationships, how we co-design with communities, how we deeply understand context, how we conduct improvement cycles with the use of data, how we develop teams, and that the items that we developed to measure those skills demonstrate some important internal reliability. So you can see those high alpha scores there for anyone that's researchers in the audience, which I think it's all of you, given the theme, that we were able to demonstrate that that reliability of the items that we are using to measure those individual competencies. In terms of the factorial validation, I'm just giving a graphic here to kind of as a visual example that we have those items that we think are attached to very specific competencies. So there's about kind of 6 to 7 items that we have to measure each of the 15 competencies. And then those competencies we think then are linked to those broader domains I showed around co-creation and engagement, ongoing improvement, and sustaining change. And we were able to demonstrate through the psychometric validation study that we did have really high factorial loadings for all of these. From going from items to the competency, and then from the competencies to the domains, we had anywhere from 0.7 to kind of 0.93, 0.95. So we had a very elegant model kind of emerged from this. And then finally, we wanted to see whether or not we could demonstrate construct validity. And we did demonstrate that if people scored high in terms of their competencies across co-creation, engagement, ongoing improvement, and sustaining change, would the theorized outcomes for that, would they also score high on that? And you'll see that individuals who had high skill sets noted that they believed that they received recognition and credibility and respect from those that they were working with to support implementation. And they also believed that those they were working with had experienced benefits. Again, those increases in their implementation capabilities, opportunities, and motivations, along with their relational capacities. So the assessment itself is open source. There's a QR code there, and the validation study is also an open source article, and the QR code is there as well. And finally, we believe that having something like a competencies assessment for implementation support can help us understand how these competencies can be built and maintained in service systems, how they can really activate mechanisms of change when we use specific implementation strategies, that the individuals that are supporting the use of those strategies, if they come with a specific skill set, they will activate those important mechanisms for change that will lead to better implementation outcomes. They will help us understand that we might need or emphasize different skills in different settings, and that the role of implementation support practitioners, professionalizing that role, could be important to establishing cultures of learning and evidence use in the systems that we work in. So I think I am done. I will stop sharing, and thank you so much for your time.
Thank you very much, Allison. Very interesting talk. Can I open the floor to any questions? No? Very quiet audience. I do have a question for you myself, Allison. With the assessment you were just speaking about, where along the process, the implementation process, like when within the process would you recommend using that? Is it something very early, or?
I think, it's interesting. I always think things can be used at multiple times. Like using them early on can help plan the team that you might need to be able to move the work forward, because I do think very few people would score very high on all 15 of those skills. Some are quite technical around data use. Some really emphasize relational work, such as kind of building teams. or cultivating leaders. And I think those are different skills. So I think they can be done to really help build out an implementation support team that can do the work. But I also think it's a great diagnostic as you think about why implementation might be struggling. Do we not have people at the table that have these skills that can really help us in the work? And I also think different stages of implementation emphasize different skills. So I think when you're in exploration stage, I think that's really different than when you're in a full implementation stage, and that different skills are probably more useful at different stages. So I think it can be used at all different times, Laura, if that makes sense.
It does, absolutely. Thank you very much. Are there any other questions?
I have just a quick question. It's really interesting, but I'm just wondering, in an Irish context, if you use that scale with your staff, are you kind of judging them and telling them they're not up to the job?
Thank you. Can you hear that, Alison, or should I repeat it?
I can. I should also just note that this was developed with two European, the competencies themselves, Irish and German. So I just wanted to note that my two partners in the work in the beginning, Bianca Albers and Katie Burke, and I should have noted that. So I don't know. I don't think so. I think it's like any sort of metric we may use to be able to support professional development on our teams. I think if you approach it in an evaluative way is different than approaching it from a professional development way. So everyone on my team has gone through this, and we've used it to kind of say, okay, where are professional development opportunities? The team really actually was excited to do it and to kind of like look across everybody and kind of see if people were willing to share, and they were, where they felt like they needed the most support in being able to grow their skills and implementation support. But as noted, I also never expect everyone to have all of those skills. So I think it's about approaching it from a supervisory capacity more as professional development and not evaluative or punitive.
Thank you very much. Okay, we'll move on to the next speaker then. So our next speaker, and thank you again, Alison. So our next speaker is Professor Laurence Taggart, and he is a Professor of Implementation Science at Queen's University. And Laurence is going to speak to us about readiness. So I'll hand over to you, Laurence. Your slides are visible already. You're ahead of the game.
Thanks very much. All right, thank you very much. As Laura said, my name's Laurence Taggart. I'm a newly appointed Professor of Implementation Science at Queen's University Belfast, and my background for the last 30 years has been working with children and adults with intellectual disability and autism, and more recently, probably in the last 10 years, looking at how to develop interventions and test these interventions for this population. So I want to share with you a trial that we've conducted. We're coming to the end of, or in the middle of, around intellectual disability and type 2 diabetes. About 10 years ago, I had a PhD student, Peter Mulhall, and we were interested, can we actually do randomised controlled trials with adults with intellectual disability? So Peter conducted a systematic review of all randomised controlled trials in this area. Then he did a series of interviews with some of the world leading experts in randomised controlled trials in intellectual disability. And then he undertook a Delphi study, and he developed a checklist to support researchers conduct randomised controlled trials with people with intellectual disability. And one thing to note is that when you have a person with an intellectual disability or autism, there's additional ethical and methodological challenges. You're not allowed to go straight to the person. You have to go through a lot of gatekeepers, and those gatekeepers cause a lot of potential difficulties to get access to the participant, in addition to all the other challenges you have conducting randomised controlled trials. Peter I flagged this up. There's issues around the participant in relation to their different learning styles. Can we use self-report measures? Do people with learning disabilities understand randomisation, maternalistic attitudes of protection? And they seem to be a higher risk group in a lot of randomised controlled trials, both within the UK and in the USA. People with intellectual disability, that is one of the main exclusion criterion. And then we have a lot of design factors as well in relation to the design itself. Can we recruit? Do people with learning intellectual disability have consent capacity? Is it a burden? And then we looked at some of the systems issues in relation to additional time, additional funding, and commitment. That was one of the biggest ones, around commitment from clinicians. How do we buy them in? How can we recruit staff? And an issue that Geoff brought up was how can we get staff to deliver the intervention as attended? So this is a study called My Diabetes and Me. And basically, we took a national UK diabetes programme called Desmond, which is rolled out across the whole of the UK for adults with type 2 diabetes, and we adapted it for adults with intellectual disability. We made a number of reasonable adjustments in relation to the programme itself. We looked at the heterogeneity and the different learning styles of people with intellectual disability in relation to the level of intellectual disability, their cognitive deficits, processing, recall, appraisals, the communication difficulties, comprehension, levels of literacy skills, different learning styles, and then how much this population is more dependent upon family and paid carers, or maybe a lack of it. So we had to take that into how are we going to adapt an intervention for this population. So in the general population, this is a one-day education program. It's got theory built behind it, and it's been shown to, through a number of randomized controlled trials that the benefits of it last for like 3 years and beyond. So this one-day program, we adapted it into a nine half-day program of 2 hours. So it's 7 interventions and two booster sessions. We kept the core concepts as the exact same as the original Desmond. We simplified it. We used a lot of pictorial representations, a lot of repetition learning, development of skills. We had specific program, first session for carers and health action. And again, working with this population, it had to be very much around celebration and fun. We did a feasibility study. So first of all, we got £300,000 from Diabetes UK. We took 2 years to adapt it, co-design, co-research it, and then we did a feasibility study in Northern Ireland, Scotland and Wales, and we were able to show that yes, that this adapted program was acceptable to this population, and we could recruit. So we looked at the challenges that we have with this population in relation to individual factors, design factors, and the system or organisational factors. And we offered a number of solutions. How would we solve those problems that you would find in a randomised control trial? And we had about 10 papers published, and we had a team identified. We have put in for an NIHR grant. And I don't know if you know about NIHR grants, but they're difficult to get, but they're more difficult to get if you apply for an open call. Was it a success? Was it a failure? It was successful. So we were awarded about 4 or 5 years ago £2.3 million to do a randomised controlled trial of this adapted Desmond intervention. And the reason why we got the grant was that we tried and we tested the underlying theories. We modified and made reasonable adjustments to the intervention and through co-design, and we redefined the logic model as well. We did a team record, with the team assembled. We were working with the Desmond Centre in Leicester, world leading centre. So we were very much at the top of our game. We did our systematic reviews, we did our qualitative, we gauged with our PPI. So we felt very comfortable, very confident. We were able to show the funder that we would recruit 450 adults with learning intellectual disability and type 2 diabetes. Now, that's one of the biggest trials, I think, in the world of this population. So the question is, did it work? After all that experience, after all those publications, after the feasibility and all this working, and you can see how we adapted it for this population, did it work? Now, if I was there with you, we'd all have a conversation. You'd be shouting yes or no or whatever. So at the end of the trial in September, we only ended up with 265 adults out of 450. And we couldn't understand why. why could we? I mean, we've done a lot of all the work, we had all the commitment from all the teams. There was 11 clinical sites across the UK. So why didn't it work? Why didn't it work? So we sort of thought about it. And then when we thought about it a bit more, this was just the research team, we realised there was a bit of a difference between some sites where they were across the countries and other sites from a geographic point of view. So we thought, okay, what are we going to do? So we thought, can we explore retrospectively organisational readiness and whether that influenced the uptake in recruitment of participants? So this is what we're trying to do. We're trying to look now. Unfortunately, we haven't done the study. We've sort of done it in a research team, but we want to go broader, and we actually want to reach out and go to all 11 clinical sites and actually look at retrospectively, can we apply organisational readiness frameworks to these 11 clinical sites. And we want to try and see, can we identify the enablers and barriers to site engagement? And also, can we compare and contrast across these sites to see which sites did better in relation to readiness and had higher engagement in the study? And again, we wanted to look at uptake and recruitment, acceptability, adoption, feasibility, fidelity, and the use of implementation strategies. So when we started, now don't forget, this has only been, we've been looking at this in the last couple of months. We put in for a costed extension because obviously with 265 participants, we don't have enough. So we put in for a costed extension of £300,000 to get another 100 potential people. And that would give us a power of 0.81, I think it is. So we wanted to look at organisational readiness. When we were exploring that topic, we found that there are scales for research readiness. Things like, have we the research team, the infrastructure, data collection? We had all that. I mean, obviously, when you involve the clinical trials unit, you have to have all that. You've got your ethics. So we were okay. We felt as a research team, we were very good. And then we started to look at, well, are there any tools? How do we go about it? I think Laura talked about it at the start. What are some of the models, the theories, the frameworks? Are there any tools to measure readiness? And I really, this was a first for us. So we found a number of tools. The RAP tool, which seems to be a clear runner here, measuring things that I've highlighted in yellow, what I think is important for our study: feasibility, measurement, cost, acceptability, alignment, and impact. And then we started to ask, well, is this scale appropriate for our population, and do they need to be adapted? There was another scale called ORIC, and again, that's looking at change commitment and change efficacy. There was another one you've heard of, CIRcUL, and looking at the inner setting of where this intervention was going to take place. And then again, Laura had mentioned to the normalisation process. Did the staff understand the purpose and the value of the intervention? Did the staff commit to supporting the trial? Did the site have the capacity and resources to carry out trials? And did the site reflect on and adapt to trial implementation over time? So, like I'm saying to you, this is our assessment of site organisational readiness, but we intend to actually apply for ethics and actually go to the clinical sites and ask a lot of the clinical research staff, because their understanding might be very different from ours. But when we looked at site, like the key site number 1, I mean, it recruited 40 people out of 36, which was brilliant. And then sites 2 to 5 recruited 29 to 39, which again is very, very good. But when you go to site 6, it recruited 23. But when you looked at the other last four sites, one site included 15, and the last 3 included between 7 and 9 people. Now, I have to put this in context to you. Some of these cities where we recruited from, we actually knew they had 4,000 people with intellectual disabilities. So how were they able to recruit to, where some of these sites would have been more rural and would have a lot less people? So we knew something was going on. So we have made assessments, So overall readiness, with these sites here in grey, were they ready? We think they were. This other site was a bit mixed and struggled. And then when we started to look at some of the assessment tools, So did we have engagement and buy-in from the senior management team? We know yes, we know they did. But if you looked at the other sites down here in the red, we already know because we did a QRI study. We spoke to some of the senior management, and some of the senior management team within the field of intellectual disability were saying, well, how could people with intellectual disabilities undertake a randomized control trial? They wouldn't understand it. So if you had that perceptions from senior management, you were going to get little buy-in, particularly from middle management and junior staff. Again, was there clear networks and communication from senior management team? Very clear in some of the sites that were recruited well, but it was poor. So the learning disability, I mean, one of the intellectual disability teams says, we have more people with type 1 diabetes than type 2, which is not right, because most people in the world have type 2. We had other intellectual disability teams saying, we've nobody with type 2 diabetes, which is wrong because we have done systematic reviews. We know you're 3 or 4 times more likely to have type 2 diabetes than the general population. Again, if we look at feasibility, have we buy-in from frontline nurses to help recruit participants? It was very mixed. Here, did really, really well, but then we struggled with some of the teams as well. We just struggled to get meetings. One team said it's not a priority. Our big priority is constipation. And that may be important as well, but we were quite surprised to hear that they didn't see type 2 was a problem. So if you don't see something as a problem, you're less likely to engage in some processes to make a change. I think Allison talked about relational dynamics. You know, what about the contact between the research team and the frontline staff? Again, we got into a lot of meetings. We were invited a lot of times in these sites to come and give talks to different teams. But again, we struggled to get meetings here. And even when we did get meetings, a lot of the staff didn't turn up. And another way to assess organisational readiness was we needed 4 nurses to be our educators to deliver the education programme. In the sites that recruited well, we were able to get 4 and sometimes more. But in the sites that had the least participants, we struggled. Just one more, 2 other couple of slides. Again, we looked at feasibility. You can just see at the site level where there was strong agreement. Again, alignment with stakeholders' priorities, very much a key priority. They wanted to address type 2 diabetes. They saw it as a problem, where these other sites, it was not a problem. And that's, again, if it's not seen as a problem, people were less likely to engage. And again, what about research culture and implementation? Again, very, very different between those sites that were positive and those sites that were poor. And again, one of the implementation strategies was we found really, really made a massive difference was having a local champion. So in these 5 sites here, they had nurse consultants in intellectual disability, and they were extremely strong in driving this study forward, from the very senior nurse managers right down to frontline staff, educators and recruiting people. Again, in site 6, we didn't get much involvement from the intellectual disability nurses. It was actually the clinical research nurse who drove the study, and then from the poorer sites, with limited involvement from either the intellectual disability nurse or the clinical research nurse. So, just to summarise within my time. It's important when you're doing a randomised controlled trial, or it's important when you're trying to implement the thing, that you look at organisational readiness at site level. This will enhance trial feasibility and fidelity. It will identify and mitigate barriers earlier. It will support equitable site participation and improve sustainability and implementation potential. And my last slide is, RCTs don't occur in a vacuum. Because if you just measure the RCT and see if the intervention works, it may not work. But is it because organisational readiness we hadn't assessed organisational readiness? So you'll not be clear on, was it a result that the intervention didn't work or organisations weren't ready? And if we don't prepare our clinical sites, we are potentially setting ourselves up for failure. And the last point is, readiness is not a luxury. It's a prerequisite for effective and scalable implementation. That's me.
Thank you.
Hopefully within my time scale.
You're perfect, Laurence. Thank you so much. Does anyone have any questions for Laurence? We've one here at the back.
Sorry, just very good talk. Excellent. Were these people involved in research before? And was it completely new to them?
Can you hear that okay?
Yeah, so do you mean the staff?
Yes, the difference in the groups. Like, is research in this area a completely new thing?
No, no. Basically, we've been involved in. I mean, I've been involved in a number of research studies, but this has been the first time we've sort of undertook a randomised controlled trial. So I don't think research. They wouldn't be new to research, and it's come down to a big issue around our intellectual disability staff doing a disservice to people with intellectual disability. We interviewed some of the people with intellectual disability, and they could clearly articulate what a study was about, what randomisation was. And in fact, whenever we got the people with intellectual disability, 95% consented. They wanted to be involved in research, but a lot of these staff were the barriers. That's one of the points I said at the start. It seems to be stakeholders are some of the barriers to engage in to getting people with intellectual disabilities to engage in research.
Great, thank you very much, Laurence. I don't think there's any more questions here. Okay, so we're actually at the end of time. So if anybody does want to leave, now's your opportunity to slip out. But there are about 10 minutes left where I'll go back through the workshop problem and sum up. So very happy to stay for that. I don't think anyone's coming into the room after us. No. Okay. So we're just putting back up the slide now. So this was going back to the workshop problem. The problem is the lack of uptake of Ireland's retrofit scheme. So these are the questions we're thinking about. And we'll just sit for a minute and run down through these and see, think yourself, do you have any answers to these before I take you through my answers? So what is the problem? Can you define it in one sentence? Remember, it's the implementation problem. We're not trying to really adapt the actual intervention, although we could do that. Is there sufficient interest in solving the problem? So think back to what Laurence was saying. What is the no-do gap? So what do we know works? And what are we actually doing in practice? And why does that gap exist? Again, we've touched on some of those things here in the different talks. And what can we do? What would be your implementation plan? So I'm just going to give you 30 seconds to think. Okay, in the interest of time, we'll start moving, because I know everyone wants to get out. Hang on. Okay, what is the problem? So my answer to that is no, I cannot summarise the problem in one sentence. There are so many problems within it. So if I was tasked with developing an implementation plan for this, I would actually need 10 different implementation plans. There's so many issues. So these are the different problems I came up with. Lack of recognition of diversity of participants. It's a one-size-fits-all scheme. It speaks to the very wealthy who have plenty of money to do this. There are programs to support poorer income or lower income households. It doesn't work for not only the lower class, but the middle class. It's financially out of the reach of many people. The next is about the high upfront costs. So it's slightly different than the kind of the one-size-fits-all strategy. It's very high upfront costs. There's difficulty selling the concept to homeowners. We haven't gotten buy-in on it. And I'm going to loop back to all of these. There's lack of tailored finance options. Landlords lack incentives. So renters aren't benefiting from it. And landlords own a huge proportion of the properties in Ireland. We have a shortage of skilled labour. So we don't have the construction workers to do the work that is needed within this. There's delays in the grant processing, so administrative delays in it. There's widespread inefficiency in it, and there's very confusing information available on it. So we could tackle any of these individual ones, but we would need a number of different implementation plans together to actually solve the problem. So it would be a huge piece of work. A lot of it would have been avoidable if they brought implementation scientists in at the beginning. If the only message you go home from here with today is implementation science needs to be embedded from the beginning to the end, no point bringing us in halfway through. Okay, sufficient interest. Is there sufficient interest? So the sufficient public interest. If you looked at any of the surveys, the general public are, yeah, this is a great idea, we need to do this, we need to take action on climate. But when you come to individual level interest, do you want to do it in your house? No, I can't afford it. No, it's too big. You know, people, no, it's a whole pile of no's. So there's only very few, well, not very few, there's only some individual level interest. So that contrast, because obviously the individuals belong to the public, that contrast is really interesting. There's also lackluster government interest. It feels like they're doing it because they have to do it. It's like mandated. They need to do things against European directives. But they have like varied priorities and pulling them in different directions. And of course, we have the changes of government over time. Is it an evidence-based solution? Is there one available? Yes, there is. Italy had a super bonus scheme, which had 110% tax deduction for renovation costs. It was hugely successful. It was credited with boosting construction sector, creating jobs and promoting sustainable building practices. So not only did they get the desired outcome of sustainable buildings, increase in sustainable buildings, they also got the jobs and the boosted construction sector. So there is something out there for us to model, but of course we didn't do that, we took something else. What is the no-do gap? So the gap is budget. If we're to think about Italy's one where they're giving 110% in tax deductions, they're basically paying for it all, whereas in Ireland we're paying for a huge amount of it. So there's a budget gap, and it's a no-do gap because we know nearly paying for it all through tax works, but we've gone a different route. The availability of a skilled workforce. So we know we need a skilled workforce, but we didn't do anything to ensure that they were there to ensure that the country was ready for it. We didn't account for diversity of participants. So we know you need to account for diversity. You need to develop things in an equitable manner. We know that co-creation works, but they weren't done. So we now have a knowledge do gap. Tailored strategic, that should be the other way around. Strategic tailored communication encourages uptake. We know this. We know you have to tailor your communication. I speak in one way here, and then I go home to my children and speak in an entirely different way. We all do that. We know that, but yet it's not done. Person-centered approach works. We know that tailoring things for individuals, co-creating with individuals, thinking about the person in an action works. It's evidence-based. But here, a structures approach was developed. And co-design overcomes implementation barriers. We know that, but yet it wasn't done. So there's your no-do gap. Why does it exist? It's because we have top-down approach to policy making. We use one-size-fits-all thinking very often. As I said, we used structure, not person-centered approach. There was a lack of implementation planning. There was a lack of impact assessment. And there continues to be. The impact is all around the numbers of houses that have been done, the amount of budget that has been drawn down. So it's focused on the outcome of interest, but not on any of the implementation outcomes along the way. And if you don't look at the implementation outcomes, then you're not doing what we were talking about at the beginning, that feeding back in that would allow you adapt what you were doing and how you were doing it, more importantly, to get better success. There was a distinct lack of readiness. You can see in the literature coming directly from the group, those responsible for the implementation of the policy, is that they are relying on diffusion without strategically designing to encourage uptake. What that is well, we know what diffusion is. If I'm doing it here and then you uptake it and it moves out and out and out. But there is a way to strategically design that so that it actually diffuses. It's like active management of the diffusion. And then there are other strategies that you should marry with that in order to successfully get uptake. And there was a lack of co-design for packages. So what implementation actions can we take? We could develop a theory of change around this and design a logic model. They're the first two things we love to do. We could adapt the intervention based on the learnings. And I put increased funding here with a question beside it. We don't necessarily have to increase the funding. That's the first thing we often think of, throw more money at it. We could just do things differently with the same budget. But actually the intervention that was put in place is not the best practiced intervention that it could have been. So maybe more funding. We should co-design tailored finance packages with homeowners, upskill the current labour force, train a new generation of sustainable building able construction workers, tailor and simplify communications and identify champions. So you heard Laurence talk about champions, and increase administration staff to avoid process fatigue. So they're the things that we can do, but what that does is makes an implementation plan that's actually much more elongated than it wouldn't reach the current targets. If we had developed this back a few years ago when the plan was coming out, then we wouldn't be where we are now, and we would actually have had much more uptake. So these are the types of things that I would do on it, and I'm sure others have other ideas. So this is the end of the workshop. I do have one slide on ethics if you want to stay for it, but okay, because this is my pet at the moment is the ethics. I'll be very quick. So ethics and implementation science, right? It involves many different types of people: public, patients, staff, policymakers, and they all have different roles. So there are different considerations and vulnerabilities. And because of that, our current ethics frameworks and even our ethics committee application forms, they don't tailor to this. So for example, if you're putting in an ethics application, say, what's your sample size? I can't answer it. What do you want to know? Do you want to know that I have 20 patients, but I have 20 patients and 100 staff, and I'm also going to look at policymakers and the public's reaction. So now I have, well, the whole population of Ireland, really. So we need to be thinking about that. There's also the informed consent element that we need to think about. Informed consent differs by the role. So somebody, a staff member, needs to have different informed consent than a patient. And we're so used to, let's think of clinical trials, the patients are the participants, but actually in implementation research, the staff are participants as well. And the public are participants, so they need a different types of informed consent. Do we need full informed consent for everyone? Can we have implied consent? What do we do? That all needs to be teased out. This is my favourite bit. Efforts at behavioural change can enhance or threaten autonomy. How do we protect participants whose autonomy is threatened? So it's very easy for us to think about the small group of like the people who are directly impacted by it. But when we're doing implementation research, it transcends those kind of boundaries of society. So by doing something, are we threatening the autonomy of an individual by nudging them through behaviour change, if that's our desired outcome, which it often is? And this is kind of echoed here. Implementation science or research takes place across a range of social and cultural contexts. And what we need to do there is be very, very aware of it. We could have a fabulous intervention that we're trying to implement, and it could work for nearly everyone. But then it so happens that maybe the traveller community are touched by it. Have we taken account for that? So the way we do that is lots and lots of co-design, especially where we can identify vulnerabilities. There's a fabulous paper on this just published last November by Taggart et al. If anyone is interested in this topic, I highly recommend that reading. Okay, so that is definitely the end now, and thank you all for staying. I hope you enjoyed it. And if any of the speakers are still on, which I think you might be, thank you all very much for your input.